I feel like I know many of you in the room. It's been a pleasure getting to know the cancer community in Bangladesh over the last, I think, 5 or 6 years. And I really want to give thanks to my colleague, Dr. Das, for the invitation and for introducing me to your society. I was asked to talk about the management of triple-negative breast cancer. You're going to see several themes that will be expanded upon by other people during the day. The overview I will give you will focus on the genetics and the epidemiology of triple-negative breast cancer, which was mentioned by Dr. Mainwaring. We'll talk about the initial diagnosis and the treatment medically of triple-negative breast cancer, particularly the role of neoadjuvant chemotherapy, and then following surgery, how to manage our patients who have residual breast cancer. And then I'll quickly go to the treatment of metastatic breast cancer, focusing on these 3 areas. So in terms of definitions, these are tumors that are ER, PR, and HER2 negative. What constitutes HER2 negative, as Dr. Mainwaring mentioned before, is a moving target. In many of our studies, ER expression of less than 1% constitutes an ER negative tumor. PR positive, ER negative tumors are oftentimes also considered as a hormone receptor negative tumor, and in more contemporary studies, ER expression of less than 10% may qualify as triple negative. We have a study ongoing at the Dana-Farber where the criteria for triple negative uses that 10% line. It accounts for about 15% of all breast cancers. It's mainly a disease that happens in younger versus older women, and women with breast cancer under 40 are 2 times as likely to have a triple negative breast cancer compared to older patients. And as was mentioned earlier, 1 in 5 women with a BRCA mutation will be diagnosed with breast cancer as triple negative. The global prevalence is here. It's 2 times more common in Black women in America. But also, if you look at outside of America, West African and Ghanaian women compared to other women of African descent have a much higher prevalence of this disease, up to 50% for women from Ghana. There's limited data here in Bangladesh, but at least one study I saw is actually alarming. It can be up to 1 in 5 women in Bangladesh have triple-negative disease. We're also learning more about the genomics of triple-negative breast cancer and now realize it is not a single entity. There's basal-like triple-negative disease and there's non-basal-like disease as well. Lehman and his colleagues have gone in to try to differentiate the different types of triple-negative breast cancer. This is their more recent paper, which distills it from 6 subtypes to these 4, and shows that there may be a prognostic stratification, meaning basal-like 1 breast cancers not only seem to have the best prognosis in red, but are also more likely to respond to neoadjuvant chemotherapy. Basal-like 2 breast cancers, on the other hand, have the worst prognosis, as noted in the blue line in overall survival. And then there's mesenchymal as well as luminal androgen receptor breast cancers. Luminal ones tend to be lobular in histology. So in terms of seeing someone with triple-negative breast cancer, the first thing that comes up for many medical oncologists is this a person that should receive chemotherapy rather than surgery? So I thought it's worthwhile to point out 3 things, which again, I believe there is a talk later on surgery. After neoadjuvant chemotherapy, we'll expand on this. Neoadjuvant chemotherapy affords the same survival advantages as surgery followed by adjuvant treatment. There is no detriment that you are not harming patients from doing neoadjuvant chemotherapy first. This was best shown in a trial called B18 in the United States. Among people who are looking at a mastectomy, neoadjuvant chemotherapy affords the option of less surgery. And in a meta-analysis published in 2007, it's almost up to 20% a reduction in modified radical mastectomy with no difference in local regional recurrence. And then among people who have node-positive disease clinically, there is growing evidence, and I'd be interested to hear what our surgical colleagues feel about this, there is growing evidence that these folks who clear the axilla clinically may not need an axillary node dissection. However, this is a caveat in that second bullet from Sloan Kettering's experience. If you have isolated tumor cells after sentinel node or microscopic nodal disease, that should be N1 MIC, there is a high incidence of positive nodes in whom the standard of care is still axillary node dissection. So really, what did I not say about neoadjuvant chemotherapy for triple-negative breast cancer? I did not say everyone should get it. All right. So how do we approach neoadjuvant chemotherapy in my center in the United States? It changed because of Keynote 522. This is pembrolizumab with neoadjuvant chemotherapy. The volunteers on the study had stage 2 or stage 3 triple-negative breast cancer. The intervention was a significant lift. It was pembro with carboplatin and paclitaxel for 4 cycles, followed by pembrolizumab and dose-dense AC for 4 cycles, followed by maintenance pembrolizumab for 9 cycles. This is a lot of treatment. It is a kitchen sink approach to triple-negative breast cancer. The comparator was here, was carboplatin Taxol, followed by AC, maintenance placebo to maintain the blind. And compared to the placebo arm, there was a higher PCR rate with pembrolizumab, which was significant. We lowered the rate of progression at 15 months, also significant. You'll note by the 95% confidence interval, which does not cross 1.0. But it was also at the cost of significant toxicities, although I will show you here. In the arm that did not get pembrolizumab, 3 out of 4 people still experienced severe toxicity. So carboplatin-based therapy followed by AC is a very toxic regimen. So instead of showing NCCN guidelines, which I think most of us are aware of, there is a process in the United States afoot to do pathway-based care. So pathways is where a group of us, just like in this room, we get together and we decide, what did the studies show us as benefits? What did the studies show us as toxicities? And where they seem to be equal, which one makes the most sense fiscally to avoid financial toxicity for our patients? So this is our pathway. It's called VIA. And it's for triple-negative breast cancer. We look at size and we look at nodes. Node negative and over 2 centimeters, or node positive and a small tumor. We are recommending Keynote 522. If that patient, for whatever reason, maybe it's lung disease, maybe it's a very severe diabetes, maybe it's pre-existing adrenal disease, it's not a candidate for pembrolizumab, we're doing the control arm of Keynote 522. We're giving platinum, we're giving AC. And if where patients are not a candidate for carboplatin, maybe it's due to frailty, we're giving AC, dose dense, followed by 12 weeks of paclitaxel. So this begs the question of why use platinum at all in triple-negative breast cancer. And this was the Prospero meta-analysis, which was just published in Breast. And it looked at the 8 trials that looked at the comparator of standard chemotherapy versus including carboplatin. There were 8 trials, over 2,400 people in those trials. And compared to the standards of care, if you use carboplatin, you improve disease-free survival. And if across the studies, the way we figure out whether the studies are some things we can trust, we look at something called heterogeneity. And the statistic for that is called I-squared. At 40%, it's moderate. You like to see it below 40%. So the I-squared here was at 41%. So the studies were sufficiently different that the conclusion may not be something that strong. At the trial level, so when you looked at the individual trials, there was also a survival advantage. So using carboplatin in triple-negative breast cancer improves overall survival. Now, when you looked at the studies, they were able to segregate the studies that looked at treatments every 2 weeks, which is dose-dense, versus the treatments every 3 weeks, which is standard. The dose-dense studies were very different from each other. The I-squared here was 71%. So that tells you that even though the survival advantage is seen, you can't really say it supports a dose-dense to show that because the studies were so different from each other. And if you look at the individual, how did the individual patients do on these studies, there was still an overall survival advantage and there was an improvement in PCR. This is the data that we use to support using carboplatin in triple-negative breast. So let's say we give people chemotherapy and then they go to surgery. The next point where medical oncology is going to ask is, what do we do for the folks who have residual disease after neoadjuvant chemotherapy? And I'm probably going to start a huge controversy by saying we don't know. So this is the 3 studies that ask the question of capecitabine for residual disease. Everybody points to CREATE-X. That is a Japanese trial, randomized trial, of nothing versus 9 cycles of capecitabine. And at 5 years, it's improving relapse-free survival, it's improving overall survival, and this will set the standard of care globally. The problem is, there was another randomized trial called SIBOMA. This was a European trial, very similar to CREATE-X, capecitabine versus observation. It did not confirm those benefits. So 5-year survival, disease-free overall was the same, but they were able to show if you're using IHC stains and can find that non-basal-like triple-negative breast cancer, there may be the benefit to capecitabine in that circumstance. That was exploratory. And then the 3rd study was done in the United States called ECOG Akron 1131. Again, triple-negative breast cancer, residual disease, a little bit more aggressive and a larger burden of disease than seen in CREATE-X. It was carboplatin was the investigational arm, and capecitabine, based on CREATE-X, was standard of care. You'll note there was no difference in disease-free survival, but you'll also note they did not see the same benefit to capecitabine as was shown in CREATE-X. So what does this tell us? It tells us that this is not, that the standard of care of capecitabine is not conclusive. It also tells me it matters who you enroll on your trials. There's sufficient data that people in Japan metabolize drugs differently than people of European descent. We're seeing that play out with capecitabine. I think it would be very important if this study of CREATE-X could be done in Southeast Asia as well as the Indian subcontinent to see where we fall into this. But at this time, the data establishing capecitabine is weak after neoadjuvant chemotherapy. We will suggest it. We'll say, we think about this. You could do it if you want, but it is not a very strong recommendation. Dr. Paul Waring also mentioned olaparib and the management of residual disease. This is the Olympia trial. It was an adjuvant trial of a PARP inhibitor, olaparib, or placebo in people with a BRCA mutation. It included people who received neoadjuvant chemotherapy and had residual disease. And for triple-negative breast cancer, it had to be at least 2 centimeters and or node positive. And at 3 years, olaparib improves disease-free survival. It improves distant disease-free survival. And among the group we're talking about with residual disease and triple-negative breast cancer, again, you're seeing that improvement in disease-free survival. So the availability of a PARP inhibitor is important, especially for people with BRCA mutations. And if you have such a patient, it should be recommended for residual disease after neoadjuvant chemotherapy. So this is our approach currently for residual disease per the pathway I mentioned, VIA. If there's residual disease and someone was treated with Keynote 522, you continue pembrolizumab. We do not add capecitabine. We do not switch to capecitabine. If pembrolizumab was not administered, we offer capecitabine. And if pembrolizumab was administered or the patient has a BRCA mutation, we give olaparib. So what about the approach to recurrent and metastatic triple-negative breast cancer? First, the question comes up in terms of the pathways. How do we give chemotherapy? It's not even should you give chemo, but chemotherapy is the only thing we have. So for a local regional recurrence, the question is based on what did you give before? Did she or he get anthracyclines? If not, we give dose-dense AC. If they did get an anthracycline previously, we go by the treatment-free interval from taxanes. And if it's greater than 6 months, we give taxane plus carboplatin. And if it's less than 6 months, we give capecitabine. The question that we all struggle with is for someone who has a local regional recurrence or in people who are presenting with stage 4 breast cancer, should we address the primary mass that has relapsed, or should we address that primary breast cancer? This is a study that was just published. It's from the Eastern Cooperative Group of the United States. It was led by Seema Khan, who's a surgeon. And she looked at how to approach women who have an intact primary breast cancer, stable disease on treatment for at least 4 months. The intervention was to stop the treatments and do local regional care versus just continuing systemic therapy. And at 3 years, there was no change in overall survival. There was no difference in the median overall survival, but there was an improvement in local regional progression. So this tells me it might be reasonable to do, but it is not a substitute to systemic therapy. When it comes to distant disease, our pathway tells us to get NGS, next generation sequencing. And if we find MSI, if we find mismatch repair, or if we find tumor mutational burden that is high, that patient is a candidate for checkpoint inhibitors. On the rare circumstance you get quote-unquote lucky and you find an NTRK gene fusion protein, there is treatment for that as well. And then Dr. Waring mentioned about genomic sequencing for BRCA mutations as well. If we find one, we offer olaparib. Should Bangladesh invest in NGS in this way? These are the reported rates of those in triple-negative breast cancer. They're not common. This is the needle in the haystack. So next generation sequencing in breast cancer only makes sense if you have access to those targeted treatments. And I will suppose, and we can discuss, it only makes sense if your other priorities in treating your patients have been satisfied. But Keynote 355 established pembrolizumab as a treatment in metastatic breast cancer. This again was done before Keynote 522, which pushed up pembrolizumab into the neoadjuvant approach. But it tested triple-negative breast cancer previously treated to pembrolizumab with chemo versus chemotherapy alone. And this is how they stratified the results based on the combined positive score for PD-L1. They looked at it was 10 or higher, 1 or higher, and then the intention to treat. I think we will all agree on that left screen that CPS greater than or equal to 10 showed the best stratification of outcomes. And if you look at their subplots here, They also show that the best predictor was at CPS of 10. What else do we have to offer patients who have metastatic triple-negative breast cancer? In the United States, the FDA approval was obtained for sacituzumab govitecan. This is an antibody drug conjugate. The target is trophoblast cell surface antigen 2, and it is linked to a very toxic chemotherapeutic, the active metabolite of irinotecan. In the ASCENT trial, it was tried in metastatic triple-negative breast cancer. One could have stable brain metastasis, and there was no line limit here. So the comparator was chemotherapy, either eribulin, vinorelbine, gemcitabine, or capecitabine, and the results were impressive. So sacituzumab shifted the progression-free and overall survival to the right. So you're seeing a pretty significant advantage. If you look at the medians here for progression-free survival, is a benefit for about 4 months median, but in median overall survival, the benefit was up to 6 or longer. In terms of the full population here that got sacituzumab, again, this was progression-free overall, and this is the overall population here, showing again about a 3-month advantage to sacituzumab over chemotherapy. So here's a summary of the efficacy results. The main bullets you should know about are in red. The progression-free survival was improved over in the population with brain metastases, as well as in the full population. It might be better in patients who had brain metastases in terms of that therapeutic benefit. The objective response rates were significantly higher, 80% responses versus 11% with standard chemotherapy. The clinical benefits favored sacituzumab in both groups, and the durations of response, you're hitting 6 months, where with chemotherapy you're about 3. So that is actually something that I do tell patients if I'm starting them on sacituzumab, that this, you can get 6 months or longer benefits with this drug. What were the adverse events? Hematologic, gastrointestinal, fatigue, as well as unlisted nervous system disorders. So again, there is a cost to even antibody drug conjugates. This drug is dapotamab deruxtecan. It uses that TROP2 as the antibody and is currently in testing in tropion. Now, the results in triple-negative breast cancer were presented by Ian Kropp at San Antonio in 21. Among 44 people with triple-negative breast cancer, the overall response rate was 30%. Common side effects were nausea, mucositis, fatigue. You're going to hear much more about this. Dr. Mainwaring mentioned HER2 low, but it is a new way to think about metastatic breast cancer based on Destiny Breast 04. I'm going to go through this very quickly because I think it will be covered later. HER2 low, as discussed, is what we used to consider HER2 negative. So it's IHC1 plus, IHC2 plus, in situ hybridization negative. The problem was also mentioned earlier, our colleagues in pathology don't have a standard way of calling something 1 plus or 2 plus. This is TDXD. It uses HER2 as well as a topoisomerase 1 inhibitor payload with a bystander effect, which is mentioned here on the graphic. So TDXD binds HER2, internalizes it, releases the topoisomerase 1, kills a tumor, and then that payload can go to adjacent tumor cells and kill them too. Destiny Breast 04 looked at people with HER2 low disease. I'm going to focus in red on the 10% of that population who had triple-negative breast cancer. For all patients, it was an advantage for about 5 months compared to standard chemotherapy. But if you look at the results in ER-negative disease, it was impressive. Again, 10% of this group had triple-negative breast cancer. Progression-free survival went from 5.6 to 8.5 months. Overall survival was almost at 10 months. If you compare the response rates to what we saw in hormone receptor positive disease, it's actually quite similar. So the response rate, about half of your folks with HER2 low triple negative breast cancer responded to this drug. In terms of the treatment adverse events, I would just point you here. This does cause pneumonitis. It was seen earlier in the clinical trials. And in the studies, we were doing either chest x-rays or CAT scans at very frequent intervals to check for pneumonitis. And at the sign of pneumonitis, radiologically, the drug was recommended to be stopped. So here you're seeing that grade 1, which is really radiologic CT evidence of pneumonitis, happened about 3.5%. But the overall incidence was over 10%, so 1 in 10. And I think in the United States, there is some reluctance on treating people with TDXD because of the risk of pneumonitis, which can be potentially quite serious. Grade 5, by the way, right, means that people were hospitalized and died of this disease, this complication. Having said that, Destiny 4 sets a new definition in breast oncology and breaks down HER2 for us. And the question is, do you even need to test HER2 now? But I think you do. HER2 low is predictive of this new class of drugs. It does change the standard of care beyond hormone receptor and HER2 stratification. The challenge for all of us will be pathology. I have been serially biopsying people who are called HER2 0 to try to get them reclassified as HER2 1. That has proven very difficult. The words of advice I got recently is that if you're trying to find this, try to biopsy a node versus the liver. That may be more productive. But again, the testing only makes sense if the drug is available. And I think kudos to your community and your country for having drug development here that is able to provide these very expensive drugs. And then finally, just reminding all of us that the biology does drive the treatments. So biology does drive treatments, and just remember that triple-negative breast cancer is not just one disease. 1 in 5 people, though, will harbor a BRCA mutation, and this does, I think we need to work towards having this, we have to work towards getting our countries to cover genetic testing, which is an important initiative of the Global Cancer Institute that we're hoping to launch with Bangladesh. The therapy in the US and Europe requires the use of somatic testing, and that immunotherapy plays a very big role in how we treat triple-negative disease. And then global access, obviously, is essential so we can achieve equity for everyone with breast cancer. With that, I will close. Thank you so much for having me.